Welcome to BAM Green, the pioneers in domestic and industrial solar energy systems in Sri Lanka. BAM Green offers you a wide range of solar energy solutions with high-quality European products together with exclusive warranties and outstanding after-sales services. Our engineering, technical and customer care teams will take care of your projects from start to completion. From inspections, system designs and installations of solar PV systems, wind power and hybrid solutions, we handle complete systems integrations. Talk to one of our solar consultants to discuss your project and help save our Earth. Go green with BAM Green. BAM Green offers you a wide range of solar energy solutions with high-quality European products together with exclusive warranties and outstanding after-sales services. Our engineering, technical and customer care teams will take care of your projects from start to completion. From inspections, system designs and installations of solar PV systems, wind power and hybrid solutions, we handle complete systems integrations. Talk to one of our solar consultants to discuss your project and help save our Earth. Go green with BAM Green.
Good morning. Thank you for joining us today. A very good morning to all of you. Welcome to another episode of monthly clinical lecture series organized by the Doctors Welfare Society of LRH. I think this is the third surgical topic in this lecture series. And today our topic is pediatric surgical pearls for the community physician. I think it's a very important topic because in the pediatric practice, you often get confused within where the boundaries lies in the medical and surgical presentation. So I think this will be a very fruitful lecture. And today's lecturer is Dr. Malik Samarasinghe, consultant pediatric surgeon and the senior lecturer, Faculty of Medicine, University of Colombo. And he's the consultant surgeon in charge of Ward 5 LRH. Dear sir, over to you to conduct your time lecture. Thank you.
Thank you very much for the kind introduction and good morning to all of you. I see part of my team also here. My clinic has been put on hold, I believe. Jayashanta spoke to me a couple of weeks ago about this. So we are trying to see what kind of topics to deal with. And on these suggestions, and after we sort of thought what might be suitable, we thought of to utilize this time effectively. We thought about dealing with these topics: inguinal hernia, hydrocele, undescended testis, acute scrotum, some problems of the prepuce, umbilical granuloma, umbilical hernia, tongue tie, ingestion of foreign body, and something about neonatal jaundice, but a very surgical perspective. But now you see, there are a wide array of problems, about 10 or 11 problems here. So to make effective use of it to this particular audience, I don't intend to do a lecture of each of these topics, which I don't think is required, right? But I just want to put out or bring up or highlight some issues which might be of value for the primary care doctor, first contact doctors, and how we can think about these problems and in our interactions with maybe a surgical specialty clinic or surgical emergency unit or whatever, right? So I think for us to be again effectively using this time rather than me giving a very didactic form of lecture, I will be probably using one slide per condition, highlighting some issues, and I would think it would be nice if we could then at each level, at each condition level, we bring up any questions that you have so that we can clarify certain things as we go on, rather than the traditional format of going through this whole presentation at the end asking for questions or whatever, which might not be, since we are talking about small, array of conditions. Perhaps I think if we did condition by condition, and then if there are any doubts, we clarify, then go on to the next condition. Is that okay? Are you all okay with that kind of format? Yeah. Okay. Now again, I mean, the intent is not to go through these conditions as for a beginner. I mean, all of you are experienced people. So I don't think I need to introduce problems, go into the basic pathophysiology or pathology of conditions, etc. So I am not going, but we'll take up some very practical issues, if at all, as we go along. And if it's up to you guys to then open it up. And if you want to go into further depth on any given topic, that's fine. I'm okay with that. Okay. Right. So regarding now inguinal hernia, by the way, these are all original paintings by me on my computer. So no copyright violations, but I would put my copyright here. Most, not all, but most. Inguinal hernia. So I think it's important for us to realize that inguinal hernia can occur at any age, isn't it? From birth, a newborn baby might be born with an inguinal hernia to an older child. At any age, it might come up. It goes across the sexes. Both boys and girls are affected by it. And sometimes inguinal hernias may be bilateral. Or they may be what are called metachrotis. It might come up on one side, and about 10 to 15% actually might develop a hernia on the other side later on. And it is not a result of closure of one side, which results in increased pressure and one popping up from the other. Where sometimes parents come and say, so it's not that. So that's something that we actually discuss and inform parents early. If they have a unilateral inguinal hernia, that there is a 10 to 15% chance that they may develop a hernia on the other side, because the hernia is already there. It may be already there. These are congenital problems. And it's not that it just pops up because this is closed, isn't it? So it's a patent processus vaginalis. This and the hydrocele we are going to talk about are results of a patent processus vaginalis, which is a developmental problem. Now, I'm not going to talk about the diagnosis of an inguinal hernia, which I'm sure all of you will know, but it's important to realize that in children, first, before that, it's important to realize that the inguinal hernia is not there always. Uncomplicated hernia, it's an intermittent swelling that appears in the region of the inguinal canal in the groin. And when we examine a child, when all of us examine a child, it may not be there at that particular point of time. And a child may not cough when we ask the child to cough or whatever to demonstrate a cough impulse. That is also not possible. So what I am trying to say is, often an inguinal hernia diagnosis has to be made purely on the basis of a history, a clinical history. And if we can obtain a reliable history where the parent or the caregiver is without doubt shows that inguinal region, that's the purpose of that drawing, the red point, isn't it? That's where the inguinal hernia comes up, and either on either side or both sides simultaneously. And if there is a swelling that the parent has no doubt that she has seen it come in there, maybe intermittently, that is good enough for us to diagnose hernia. There is no other condition where an intermittent bulge comes up in that area and then disappears. It is an inguinal hernia. So that in itself is adequate, a good, reliable history. So of course, sometimes the parent is wondering, is it the left or right or whatever. So then it's okay. Then we said, all right, go back home, have a good look and see where it's coming up and come back and tell me. That's all, right? Imaging is, if it is not there clinically at the point of time the image ultrasound is done, it's not going to be there on ultrasound. So imaging, ultrasound says normal, does not mean that there is no hernia, isn't it? So the role of imaging is limited in that sense, right? So a good clinical history is actually all that is required. And if you can examine it and you see it, then that's bonus. So the inguinal or inguinal scrotal swelling, which is intermittent, associated is straining, and usually it is painless unless it is complicated. So that's the next question that we have to verify. At the point of seeing this patient, is it complicated hernia then and at that point of time, in which case it becomes an emergency with a background history of which suggests a hernia, or sometimes the child may present for the first time with a complicated hernia. So a complicated hernia, irreducible hernia, is painful. But if it's a young little baby who cannot communicate, it will be an irritable baby, isn't it? And the lump will be there, not producing, it will be tense and it will be tender. So that palpation will make it the baby more distressed, right? And it's irreducible. So if it is complicated, then obviously as a primary care physician, our duty is to send this child for admission, emergency admission, rather than sending them home. So it is a case of an admission. Whereas if it's an uncomplicated hernia, then of course the treatment is to refer to a surgeon or pediatric surgical clinic, right? Now, again, another thing about this referral thing, the last point that I put up here is to realize that younger the baby or the child, the more urgent the surgery. So there is no place to say a little baby, newborn baby with the inguinal hernia. If you're saying, I will bring the child when they are a bit bigger, 1 year, 2 years, that is wrong management. A newborn baby's inguinal hernia is an urgent thing. We don't even keep them on waiting lists. We try to get them in and by somehow do them on post casual morning or whatever. So because the incarceration complication rate in a newborn child's inguinal hernia is much higher as a percentage. Also, the complication progresses from incarceration to strangulation much faster. The bowel is flimsy, so it becomes ischemic very easily. And sometimes picking the complication up is difficult. Baby is not going to say, family, they're not, isn't it? Baby is just might be a little irritable. Nobody will realize that there's an inguinal hernia, which is complicated. Not even the parent might notice until sometime later. So that window is very small. So therefore, newborn babies, young infants, inguinal hernia is a relative emergency. Refer them early, and the surgeons also will treat that as a urgent problem rather than a very long one that will be, or rather than keeping the child on a long elective list. Okay, so much for inguinal hernia that I wanted to sort of discuss. Are there any other questions, clarifications that you need about that before we move over to the next topic? Okay, so shall we then move on? All right, let's move on then. So related problem to the hernia is the hydrocele and the cyst of the cord. Related because they are all derivatives or problems that come in the range of problems related to a patent processus vaginalis. So the hydrocele and the cyst of the cord also can occur at any age. And the difference from the hernia is that the region, the anatomical area is the same, but the swelling is persistent. It doesn't demonstrate the intermittency of the hernia, which comes on when the child strains. Here, it is always there. The swelling is always there, but it may fluctuate in size, particularly in the child who is ambulant, who is walking. During the afternoon, evening, as the day progresses, when the child is an active child on his feet and active, then the fluid tends to gravitate from the peritoneal cavity moving to the scrotum. So the hydrocele in a child who's ambulant is more prominent, tends to be more prominent towards the end of the day. But when they wake up in the morning, because child is sleeping supine, gravity again pulls some of the fluid back into the peritoneal cavity across this patent process vaginalis. So the hydrocele may be less tense. It will be probably more lax, even slightly smaller during when they wake up in the morning. So that is not an unusual phenomenon, that fluctuation in size. But generally, the swelling remains. It doesn't disappear like a inguinal hernia. So clinical examination, fluctuation demonstrating that it's a collection of fluid, and transurination will be obviously there. But again, a problem is in the young child, the infant, because their skin is so thin, the subcutaneous fat may not be that thick. Therefore, even an inguinal hernia, particularly inguinal scrotal hernia in a small baby, will be transilluminated. So just the presence of transillumination in a baby does not necessarily exclude the inguinal hernia. So that's the other little practical point that I want to bring up. Right? Now, to differentiate the hydrocele from the cyst of the cord is that the hydrocele incorporates the testis, which is within the fluid collection, whereas the cyst of the cord is a cystic swelling which lies above the testis. So there one can separate, or there is a separation between the testis and the cyst of the cord. Now, some people diagnose epididymal cysts, which are also located like this, but epididymal cysts do not occur in children. Right? So that's a wrong diagnosis. Children have a cyst of the cord, which is a part of the processus vaginalis spectrum of disorders, right? Also called cyst of the cord or hydrocele of the cord, different names. And now, so this swelling here, or sometimes it might even occur slightly higher up, even inside the cyst of the cord can even occur within the inguinal canal, and that sometimes can get confused with a hernia, but it doesn't reduce. So then the question is this a complicated hernia? Sometimes the casualty we get, a cyst of the cord hydroceles rarely even present almost overnight. So-called acute hydrocele, it hasn't been there. Suddenly the parent sees the swelling and brings. So for the OPD, the doctor also, it's a problem. This was not there, it has come, and inguinal swelling has arrived. Now, can that be an inguinal hernia or a complicated, irreducible inguinal hernia? Because this doesn't reduce, or is it a hydrocele? Difficult decision, right? But the hydrocele is generally not painful, not tender. Incarcerated hernia is tender. The child is irritable. If you go and palpate that area, it's going to cause distress. Hydrocele isn't. So that is one way of clinically differentiating for the hydrocyst, which has suddenly appeared out of the blues, the acute cyst of the cord. But at times, even for the experienced person, it may be difficult to differentiate. And here is a situation where imaging can be helpful. Ultrasounds can, in that situation, can tell us, look, this is filled with fluid, it's a cyst, versus an inguinal hernia which contains bowel loops or omentum. Right? So that is a situation where it may be of value. Otherwise, a straightforward hernia or hydrocele, the ultrasound doesn't tell us much, anything new. Right? Okay, so now in management also, although this hydrocele cyst of the cord is part of the spectrum of a processus vaginalis, we do not rush in for surgery in an infant, because most of the hydroceles over time, over the first 2 years, 3 years, it resolves spontaneously, because the processus vaginalis tends to close up as time goes on. Then one might ask, then why doesn't the hernia close? Because it also belongs to the same spectrum of problems. Because the hernia, the patency is much wider. So it's unlikely for it to close spontaneously. That is why, because it's wide only, that's why bowel contents or some fat omentum or something comes up. So that is unlikely to close, and also it gets complicated, tends to get complicated. The contents get incarcerated, stuck. Right? So therefore, there is no expectant management. I'm repeating, there is no expectant management of inguinal hernia, but the hydrocele is managed expectantly in the infant. So there is no reason, if one has definitively or confidently diagnosed a hydrocele, there is no urgency to refer the patient into a surgical clinic if it's a baby, young baby. Right? One can easily, I mean, if you are confident in a diagnosis, you can advise the parent to watch for the first 2 years. If it persists, then bring the child back, or to review at 2 years, and then we will see if it needs surgery. So if it hasn't resolved by 2 to 3 years of age, it's unlikely to resolve spontaneously. Although occasionally we do see hydrocele even 3 to 4 years, which do disappear. It does happen, but the chances are slimmer. So the decision whether to intervene surgically or not can be made at around 3 years of age in the case of a hydrocele and the cyst of the cord. Medications like antifilarial treatment, etc., have no place, isn't it? Because the pathology is not that. Pathology is that of a patent processus vaginalis. That is the problem. So we see sometimes, medication being given, which is actually inappropriate treatment in the pediatric hydrocele. Okay, so that is, any questions regarding hydroceles before we move on? Right, so then in the absence, anybody can put their hand up at any point. So we'll move on then. How's the artwork? Okay, no? Right. So, undescended testis. Again, This may be either unilateral or bilateral. And it is here again important to realize when in a baby, newborn baby, young, let's say neonate, what are the red flags when it comes to undescended testis? Right? In other words, when do we need to quickly get this child into investigation? Or when can we sit on it for a while? So an early endocrinological evaluation is required if a disorder of sexual differentiation, a DSD, is suspected. Right? In other words, if it's a small baby with a small penis, right? Or if there's hypospadias in the presence of empty scrotum, then it could be a virilized female with a hypertrophic clitoris who's manifesting a bilateral undescended testis. Today in the clinic, we saw a child. By scrotum, absolute looks normal. Urethra even opens, not even hypospadia. Urethra opens, external urethral meatus is at the tip of the so-called penis, which happens to be a hypertrophic clitoris. Labioscrotal folds are fully fused, right? 46XX. So if it's bilateral undescended testis, think this could be a virilized female. If it's undescended testis, unilateral or bilateral with hypospadias, this could be a DSD, a virilized female or some other testicular, other gonadal dysgenesis. So they need to be, if the child is young, the more important it is, newborn even, quickly get an endocrinological setup. But in the absence of that, if it's a simple, otherwise normal male child with a unilateral undescended testis, then there is no urgency. You don't have to put the baby in the next ambulance with the mother and transfer to a pediatric surgeon. Because about 50% of these testes descend spontaneously within the first 4 to 6 months of life. Right? Therefore, in such instances where there is no red flag, the appropriate action of the doctor who sees the baby as a newborn with the undescended testis is to review the child at about 4 to 6 months of life. I emphasize this again. Review the child. Set up a date for review. Again. Right? But often we hear of stories where the mother has been told, so they have been waiting till they are 5, 6, 7 years old, till they are loku enough, and then they decide, so that is sometimes the bad advice which happens, which we can avoid by saying, come back at 4 months, come back at 6 months. Officially, if you have documentation, put the date down, review on such and such a date. There, it is there, black and white, so they have to come back. And then we will see them, you can see them and see, look, has this come down? If it has not come down, then at that point, you refer to pediatric surgeons who then have this window of opportunity. We know after the 4 to 6 months, it's not going to descend. And we need, nowadays, the current recommendations are to operate in those instances before the child is 1 year to 1.5 years. Current recommendation is 1 year, but I'm sure up to 1.5 is very acceptable. So that is the window. So there's no point again waiting till 1 year and saying, put the operation, because pediatric surgeons are waiting this also, isn't it? Which one has to be aware of. So at 4 months, you can make that decision. It's not going to come back. 6 months, it's not going to come down if it hasn't come down. At 6 months, you refer, right? So at that point, the surgeon will set up an oculopexy and laparoscopic, they'll do a laparoscopy if the testis is not palpable in the groin. Again, ultrasound is not going to help much. Often ultrasound is done. For the surgeons, they'll go by palpation. If they feel it, they'll explore the groin. If they don't, they'll go into the laparoscopy. Ultrasound sometimes confuses the picture because if the testis in the infant is not in the scrotum, the other differential diagnosis is if it's palpable in the groin, whether it's a retractile testis. So the examining physician has to gradually milk this testis down or attempt to milk it down to the scrotum and see whether it comes down to the scrotum. That is purely clinical. But what happens is when they go into the radiologist for ultrasound scanning, ultrasound scan, the radiologist puts the probe in on the groin, boom, the testis gets pulled back into the groin, retractile testis. The radiologist says our testis is in the inguinal canal, undescended testis, then they are referred for surgery. And when they come to the surgeon, the testis is nicely hanging in the scrotum, isn't it? So that is a mistake. It is made. Retractile testis is a clinical diagnosis. Radiology confounds the picture. No ultrasound for undescended testis is the message. Or it's unnecessary, it can confuse. So because the surgeon is not going to make decisions based on ultrasound. So when they come and show the scan, okay, yes, we see the child. Right? So no decision is made on ultrasound scan. So but we also have to keep in mind early surgery might be required in certain cases of undescended testis. That is when the testis is associated with an inguinal hernia. Sometimes it is. Right? So undescended testis with inguinal hernia, because inguinal hernia in the baby is an urgent thing. We discussed about that. So because of that, the hernia merits early treatment. So at that point, if the testis also happens to be undescended, we will simultaneously do a orchidopexy in a younger child if they have an inguinal hernia associated with undescended testis. So this diagram demonstrates this is for the retractile testis, the importance of whether you can milk it down into the scrotum versus the purely undescended inguinal testis. Okay, that's so much for undescended testis. Any questions? All right, let's move on. Acute scrotum. I have used more color here. So imagine now color mixing on the screen. Right. Right. So acute scrotum is, well, when we use this term acute scrotum, acute abdomen, I'm sure we all know, and I just want to reiterate this acute scrotum abdomen, it refers to a condition where we contemplate or we think of the possibility of acute surgical intervention being needed. So that is what it means, isn't it? Acute abdomen, this is a condition, okay, acute surgical intervention may be needed. So that's when we use the term acute abdomen. Then obviously the primary care physician in the OPD, they will do a surgical referral rather than abdominal pain due to gastroenteritis or something, then we know that's not something that goes. So acute abdomen, it refers to, we don't know for sure whether surgery will be needed, but when we are thinking, this may be surgery. Right? Similarly with acute scrotum, isn't it? Acute scrotum refers to acute onset scrotal pain plus or minus swelling, where we think urgent surgery may be required. In other words, what requires urgent surgery is a torsion of the testis. So whenever a torsion of the testis is thought of as being a possibility, you're not sure of the diagnosis. If we think torsion could be, then that is the acute stroke. Right? So testicular torsion should be considered in any boy with acute onset scrotal or testicular pain. It has to be considered. One might exclude it, but that's the first thing that has to come to one's mind. So sometimes it is abdominal pain that is prominent, right? And therefore it is imperative that the scrotum is also assessed in children with acute onset abdominal. Something which we want to stress over and over again, because sometimes it has happened where even I have seen even appendicectomy is done. And then later post-op day 1 or 2, they realize, I say the scrotum is sore, testicle is dead. That has been the problem. So look at the scrotum in the male child when there is abdominal pain as well. Now in testicular torsion, the testis is swollen and tender. And the ipsilateral scrotal wall may also be decussed. So pain is there. Pain is definitely unilateral. Very rarely you can get simultaneous bilateral testicular torsion. Extremely, I have never seen in my life, but it has been described. But it is usually unilateral. The thing is the pain, and there is testicular tenderness. Swelling develops a little later on in the, it might take a few hours for swelling to develop. But if the testis or scrotum is painful and on examination, if the testicle is tender, one has to always think of the possibility of testicular torsion. Now, there are other causes that might produce similar symptoms. We all know epididymochitis, torsion of a testicular appendage, which is not uncommon. Another physician just walked in. I always put you as an old surgeon physician. And now, so yes, so it's if it is unilateral and testicular tenderness, think of torsion. It may be a torted testicular appendage possible, but that I think is a diagnosis for a bit more experienced person. But if there is testicular scrotal pain, tender when you palpate the testis, then assume that it is torsion, right? Yeah, but there are conditions where I think for a reasonably experienced doctor will be able to diagnose something like an idiopathic scrotal edema. If the scrotal, it's edema, the idiopathic scrotal edema refers to a condition where the soft tissues, the skin subcutaneous tissues are edematous, often an angineurotic reaction, but maybe sometimes a reaction to a little ant bite or something. But often we don't know. That's why the term idiopathic. But because the areolar tissue of the scrotum is so lax, that edema spreads, and it spreads across the scrotum, and you can usually both the sides of the scrotum are involved. They are swollen. That swelling might even extend to the groins and the perineum and even into the penis. Right? So extensive swelling crossing the locality of the testis to other regions indicates that the edema or the inflammation seems to be mainly in the subcutaneous tissues there, right? And testicular, one can often feel the testis through the edematous skin. It's not very tender. They may have a little bit of distress because of the edema. There can be a little bit of pain, but it's, if one has seen testicular torsion, one realizes testis, torted testis, you cannot handle without distressing the child, but in idiopathic scrotal edema, you can. So that is a condition where to a relatively experienced doctor, they can differentiate. Look, this is not torsion. And then that at that point, if one is confident, you can initiate treatment with antihistamines and maybe paracetamol, plus or minus if you think there may be infection, okay, antibiotic, oral antibiotic, and even managed as an outpatient. But the question is, if one thinks that there is a possibility that this is testicular torsion, so in other words, if you cannot confidently say it is not torsion, if there's any doubt that it is, then it must be referred to an emergency surgical facility without delay. So patient must be referred to an emergency surgical department for assessment if testicular torsion is suspected. Emergency surgical exploration will be required if testicular torsion is suspected. So that is the whole rationale is there. And one should not waste time trying to get imaging, ultrasound scans done to see whether any be torsion or not. That is a waste of time. We could be losing valuable time when it comes to testicular salvage. Okay, so I think that suffices on acute scrotum. Again, any questions? Yeah. Yes. Yeah.
Sometimes they come after the school, they are not complaining. They come to the parents, sometimes they come around 3 o'clock, 4 o'clock. Should be immediately attended by the doctors there, should we go to the ward and
now if I'm seeing that problem through different angles now. So if we are first thinking, if there is pain, the event, but there is a painful scrotum, right? One has to think of the possibility of torsion, because often some trauma, it can be a red herring, isn't it? We have seen cycle padda vaduna, and okay, pine parak football vaduna. So a trauma history can be associated still with a torsion that cannot exclude a torsion. So the bottom line for me is, if there is pain plus or minus swelling, we are always thinking about the possibility of torsion. And then whether it's scrotal hematoma or testicular hematoma or whatever, that can be sorted out later. But think torsion, if there is pain, swelling, that is my message if that is the worry. But then if there is no pain swelling, and if it is a problem of abuse and the medical legal forensic, then that's on a different wicket there, right? But if there's pain swelling, don't let the trauma history distract you. Yeah, so I think I'm glad that you brought it up. So a history of trauma, which may be innocuous as some kid just, squeezing his scrotum, to a kick in his scrotum, either due to a fight or a game of football or whatever. Right? So trauma can be associated with torsion. So that shouldn't be a distract. There's testicular pain, swelling, think torsion. Yeah. Thanks for bringing that up. Okay, shall we just move on then? Okay, so problems in the prepuce. Again, these are common issues. I have done some drawings here. Now, the first drawing on the left is to just to demonstrate the normal prepuce in a young boy. And this is a prepuce which we all know has an outer and an inner layer lined by skin. Then we have the gland penis again lined by skin. And the thing what we have to realize is that in the newborn, the inner layer of the prepuce is adherent to the glands penis. So demonstrated in red here, those are physiological adhesions which are present at birth. Therefore, in a newborn child or a young infant, the prepuce cannot be retracted. If the prepuce is retracted, then you have to think of a problem like hypospadias, for example, where the prepuce has formed properly and therefore it is all open. Right? So normal newborns, prepuce is not retractable due to these physiological adhesions. And with time, which varies in some maybe in a few years, might take about 10, 12 years even, with penile growth happening, organ enlarges, the adhesion between the inner layer of the prepuce and the glands penis start separating, loculated. It doesn't happen all together in areas, and then slowly with growth, the skin also stretches, and the prepuce will be retractable with time. And during this process, I said the separation occurs in a sort of a loculated manner. Sometimes desquamated dead cells from the inner layer of the prepuce and maybe the glands, they might collect in the areas where the separation has taken place and present with a lump on the glands penis, the so-called smegma pearl, which is a common thing and which is like a spot diagnosis. Isn't it? So the people who are aware of this and who have seen this know it. As you see it, this is a smegma pearl, and you just reassure the parents and say, look, as the child grows, the collected, the desquamated, the epithelial cells will just discharge through the prepuce. But for the uninitiated, they will refer this patient to a surgical clinic. And we see this happening often, saying a lump on the penis, a growth in the penis, right? And also it comes when the desquamated cells then start escaping from under the prepuce, it will be a pasty whitish discharge. Then we see balanoposthitis, antibiotics. That regime also, cycle of events also beginning. So it's good to be aware of this. The prepusal pearl, the lump, recognize it as a prepusal pearl, nothing pathological. And the discharge which can result due to that also is physiological. It's not in infection, will result in a liquidy kind of discharge, the pus. There will be pain, discomfort, there may be some swelling in the prepuce, isn't it? So that's when there is actual inflammation, right? Versus the discharging prepusal pearl. But of course, true phimosis does happen in children, and the commonest cause of true phimosis is balanitis xerotica obliterans. I'm sure most of you have seen that, where the prepuce doesn't retract, and the prepuce, the orifice, the skin there looks a bit scarred and it is whitish, and even the prepuce is density sometimes adhered to the glands. So there, when you put the prepuce under stretch, in the physiologically non-retractable prepuce, you can see the tendency of the prepusal orifice to open like a little rosebud trying to open. But whereas the true phimosis, when you put it under stress, it doesn't open. It's like a stubborn fellow, when you try to open the mouth, it closes the mouth even more tightly. That kind of appearance you get, everything like is pulled in. without opening up. It's just pulled in because of the scar, right? So that is a true phimosis. And a true phimosis due to BXO requires circumcision. There is no two words that need circumcision. Otherwise, things get worse. But these don't need circumcision. And also, just mere ballooning of the prepuce on micturition does not need warrant circumcision. That does not cause damage to the kidneys, isn't it? So ballooning is not the issue. But if the child is distressed by even a physiologically non-retractable prepuce, where some children find it uncomfortable to pass urine, sometimes urine collects in the prepusal sulcus when it balloons, and then after that, when he puts his clothes on again, some urine leaks from that sac, from the sulcus, and his clothes get wet. So then the child is then in an embarrassing situation. So if there is, or he gets recurrent attacks of melanocystitis, then one might consider even treating the non-retractable prepuce. But that again, before you go into surgery, you might, that's the instance where you might think of your topical steroids as a place, isn't it? Something like betamethasone or hydrocortisone topically. But again, it shouldn't be prolonged. We see sometimes children on steroids for months and months and months. That again, I don't think is a good thing, because the problems of steroids, then you get the fungal infections and various other things starting to happen. So if you are giving a course of topical steroids, make it short, maybe up to 3-4 weeks max. But not, if it's not going to respond by then, I mean, it's not going to respond. Right? So don't make it long if you are trying that. And if you are using the steroid, use it for the correct reason. That is a physiologically non-retractable prepuce, which is causing distress. If it is not, then just let it be. Just ballooning, reassure the mother. It's not going to worry as long as the child is not distressed. Let it be. Allow the child to grow 10 years, 12 years, even if it is necessary. Right? With the growth, and it separates. Some children are more mature, so their penile growth is more than others, and there the separation happens earlier than in other kids who probably are too slower. Right? All right. So again, how to recognize the prepusal pearl, and you must be able to recognize real phimosis, particularly in the association of balanitis xerotica or prepuce. Any questions? Okay. Now, paraphimosis again. Sometimes it can get confused with edema around a circumcised penis. Sometimes we get a boy with a circumcised penis also who has developed edema, like idiopathic scrotal edema. So this edema can spread into the penis and appear like a swelling, like a puff of swollen tissue around the penis, and admitted as paraphimosis, right? But the vital thing that has been missed is this child has had a circumcision, and a circumcised child cannot have paraphimosis, right? So there it's just edema, but there is no constriction. Whereas in true paraphimosis, that happens when the prepuce is retracted and the prepusal orifice now, which has been pulled back beyond proximal to the corona glandis, acts as a constricting bag around just below the corona glandis, and then that constriction leads to edema, and that becomes uncomfortable. So it's important to differentiate the two. And true paraphimosis, if diagnosed, even is a condition that can be treated in the outpatient department by a reduction, pulling the foreskin back over the glands. Often even without sedation, we can do it. Some kids it may be difficult. Some kids may therefore need admission to do it under some sedation, rarely under general anesthetic. But often it can be just pulled over if a doctor is confident enough to diagnose it and then to do the procedure without too much, of course, distressing the child. Okay, shall we move over? Yes, I think the umbilical granuloma, I'm sure you all have you all are aware. So when it is visible, like in the picture, the red, pinky, fleshy mass at the umbilicus in a baby whose umbilical cord stump has just sloughed off a few days or instrument like a mosquito artery, open up the umbilicus a little bit and have a look at the depths to see whether there is a little granuloma. And often it is, in which case then you don't have to treat it as for an oncologitis, antibiotics, and get on to another cycle of treatment, in the wrong direction. So that is about the diagnosis. Treating also has, I think, now changed quite a bit. There was a time when people used to use silver nitrate, copper sulfate, etc., which can be a little, damaging to the surrounding skin also. And then, of course, we as surgeons used to admit these children, bipolar diathermy in the theaters and all sorts of, things, traumatic things. But now the beautiful thing is, is salt, table salt, isn't it? I'm sure we all may be aware, but if you are not, I think that is the biggest change to me in management of these OPD-related issues, is realizing that salt, just the ordinary table salt, works brilliantly on this. So all that has to be done is you take a little bit of salt, sprinkle it on the granuloma, wait for half an hour, wash it off. You can then tell the mother, go home in 3 to 4 days, see if it is still there, put a bit of salt like what she saw you doing, wait for half an hour, wash it off, 2 or 3 such sessions, it is gone. Right? Some people say put it twice a day for 2 days, 3 days, whatever. So different regime. I don't think there's a standardized thing. But that's the way we do it. Salt. But important is not to let it be in contact for a long period of time. So about 30 minutes and wash it off. Right? Because suppose there is a risk that it might erode a little deeper than it should do. That causes a desiccation, drying up of the tissue there. It gets sort of cauterized again, like a chemical cauterization. So small granules. So that normal tables of small granules on the surface, wash in 30 minutes, repeat in 2 to 3 days. And you can tell them if it has after 2 or 3 such applications, if it's still there, to come back, and then you can redo, right? So that is the lovely thing that we have learned recently over the last few years about managing umbilical granulomas. So on the topic of umbilical conditions, umbilical hernia is the next topic here. Again, here, I don't think diagnosis is a problem for any one of you on umbilical hernia, but it is important to remind ourselves that complications are rare when it comes to umbilical hernia in comparison to the inguinal hernia. And the vast majority close off spontaneously in the first 3 years of life. Right? Therefore, expectant management is the recommended treatment for umbilical hernias in children under 3 years of age. We don't go and rush. So you see the contrast between the inguinal hernia. Inguinal hernia, younger the child, earlier the surgery. Umbilical hernia, we sit back. We sit back for 3 years, like the Hydrocele, and await spontaneous resolution. But in the minority of patients who may have complications of a hernia, like incarceration developing earlier on, where that group does need surgery. So it is the child who develops complications at an age under 3, or the child who has a persistent umbilical hernia after 3 years of age, in which case it's unlikely to close spontaneously. So those are the children who we offer surgery. So I think when you refer again umbilical hernia, you can keep that in mind. There's no point rushing in a young infant or a toddler under 3 to the surgeons too early unless the patient is symptomatic. And maybe even describing. Sometimes the incarceration episode can come and reduce spontaneously, or the mother just puts it a bit and then our doctor usually, and you realize, look, this is stuck and it has gone back. Then you have to treat it as possible incarceration, and then you might have to refer the patient on for surgery if it's even a younger child. So tongue tie is another relatively common thing. Here there is some controversy, timing of surgery. So tongue tie refers to a short frenulum, isn't it, which tethers the tongue, and often it can be recognized when the tongue is child tries to protrude the tongue, that it has like a little heart shape in the tongue as it is tethered back. Of course, the older child might say, that you can't put the tongue out, and so they might be finding it difficult to lick ice cream cone or something, isn't it? So again, timing. Surgery is, there are some people, if you read the literature, who recommend early in infancy, first few weeks, months, as an OPD procedure, the people divide the frenulum. I have never seen it done here, neither have I heard anybody do that practice here. There may be some people, I don't know, but amongst our surgical community, we don't. Because on the other hand, not every baby with so-called tongue tie will develop problems, right? So unless it's really tethering the tongue. So generally feeding problems are uncommon, although it is described. But speech articulation issues may happen. So I think what we generally practice is at about 1 year or little over a year, we review the child again. And if it's a subjective thing, if we feel that the frenulum is tight at that stage, then we might offer treatment around a year. Then other group of children who come on is with sometimes articulation problems, a little older child, and then of course we might offer surgery after deciding whether this is an articulation problem due to the tongue tie. Some people are brought because of stammering that has no relationship with tongue tie. So sometimes it might help to get a speech therapist's opinion and say, look, do they think whether this is due to the tongue tie? And if they do, then we can use a surgical option. And then, of course, followed up by speech therapy. Yeah. So that's one, again, recognition. And, well, everybody to be operated versus a selective operation. I favor the selective operation. Okay. Can I go on for 2 more topics? Is it okay, Dhamika? Foreign body ingestion is another important thing. So one of the topic is ingestion, but when it comes to that's what I was told to discuss, or we decided to discuss. But as the primary care doctor, it's important to make a decision whether it's a airway or alimentary canal problem. Is it ingestion or aspiration, right? So, so if the child has choked or had been coughing around this incident, has at present difficulty in breathing, noisy breathing, which may be either a stridor or a unilateral wheeze or on one side, all that suggests an airway issue of an aspiration rather than an ingestion, right? And that has to be treated as an airway emergency. Obviously, there is no room for sitting on it. They have to be admitted in or even in the emergency department. People who can handle the airway have to be around. And then maybe a quick ENT or something you have to think of. Decisions may have to be made about bronchoscopy, etc., oxygenation issues, all that. So that becomes an airway emergency. On the other hand, ingestion, if there is persisting dysphagia or drooling of saliva, that suggests a foreign body in the esophagus, and it has lodged in the esophagus, obstructing the esophagus. That also becomes distressing situation because the child cannot swallow, right? So that also has to be admitted, obviously, to investigate further and intervene early. Then again, what was swallowed is an important issue. Button batteries and magnets, they need urgent attention. So if there is a definite history of, look, this could be a button battery, this could be a magnet, there is a remote playing around there also, those children also have to come into emergency department admissions. And then if something was swallowed, is there a toxicology risk or not, depending on what was swallowed, also has to be borne in mind. So if they come in, I think baseline investigations are the X-ray of the neck, chest, and abdomen, isn't it? And these are just to illustrate, again, foreign body lodged in this upper part is again distressing. This could be airway or the esophagus. A lateral X-ray might help us to tell if it's airway or not, because the airway tends to be more anterior than the esophagus, which is more posterior. And also the 2 common things that are worrying. The coin is very common, isn't it? Versus the button battery, and the button battery has a typical radiological sign, what they call the halo or the double ring, double edge kind of appearance on the X-ray. You can see, I'm not sure whether it's very clear there, but like 2 rings in the periphery, that's the battery. So if it, because the issue is if it is a battery, it becomes an urgent thing, it has to be retrieved early. The coin, well, this location makes it urgent to retrieve, because if it's high up in the esophagus, it can get reflux, come back, fall into the larynx and even obstruct the airway. So if a foreign body is up here, it becomes urgent. But if the foreign body has gone down into the stomach, if the object looks very scary like a nail, but again the urgency is not that much. Right? So in managing, in general, if the foreign body reaches the stomach, it's bound to be expelled in the feces in most instances. Therefore, watchful waiting is probably the best option in most instances. But long, rigid, pointed objects like hairpin and that nail that I showed you in the picture are a little bit more risky because they may perforate the bowel at points of angulation and fixation. Within that body has to take curves like the longitudinal flexion, it might get stuck, right? If such an object stays in one place, that is on X-ray, they are obviously followed by the X-ray when they are in the abdomen. If they are not progressing in 3 to 5 days, then one has to think of intervening either surgically or endoscopically, depending on where this is, and removal should be considered. Again, but here in jaundice, we might have imaged further with CT scans, etc. If the foreign body is lodged in the esophagus, it should be removed urgently, as I mentioned earlier, using an endoscope. And the button battery in the esophagus is an emergency. We don't delay. We don't wait even night admission. We won't wait even till morning. Let's wait. No, that's dangerous. So button battery lodged in the esophagus, emergency. Button batteries reaching the stomach do not harm if they keep moving along the GI. So it's that prolonged contact which is the problem. And removal should be considered if they remain in the same place in the stomach, that is for more than 24 hours. But if it's going down into the gut, it's bound to go down. Magnets also, a single magnet is not too much of a problem. But if more than one magnet has been swallowed, it's a problem. Because these two magnets can then stick on each other across the bowel wall and trap a bowel wall between the two magnets. And that can lead to ischemia, damage, fistulation, peritonitis, anything. It's dangerous, right? So more than one magnet swallowed again becomes a dangerous thing that needs to be admitted. Final topic. This is, I'm not going into it at all, just one slide. Neonatal jaundice is a huge topic and it's beyond us, it's the domain of the physician. But I was told to talk about it. I will just mention something. One thing is to keep, jaundice is so common, physiological jaundice is so common. But just to keep ourselves keep on saying this to ourselves, that whatever the age of the baby, maybe the first week or whatever the age, never assume the jaundice to be physiological if the stools are pale. Pale stools means there's cholestasis. Cholestasis is never physiological. Right? And one has to think of biliary atresia. Biliary atresia is not the only cause for obviously a cholestatic jaundice, but the problem is biliary atresia, if we are to intervene, it is time bound. We need to intervene before they are 60 days old, at least, for there to be any hope of effective treatment. So, if the stool is pale, regardless of the age, don't think physiological jaundice. It has to be investigated ASAP. And biliary atresia is excluded or diagnosed and managed ASAP. So, that is what I just wanted to mention about that. And I think it pays to be aware of what the normal stool looks like, is the color of the normal stool, and learn to appreciate what a pale stool is. Now it is in the CHDR, they have the pale stool, but still that might be deceiving, nothing like seeing the real thing, isn't it? I try to recreate the real thing here, but I don't know, it may not be that realistic, but a pale stool one has to recognize. Right, so that's the end of it. If there is anything that you would want to bring up, I can. I'm happy to answer if the time permits.
So this has a chapter on antibiotic use in children, and an annex on a few lines on the principles of antimicrobial therapy in children as well. So this book can be downloaded. I saw it being shared on the doctors group also as a WhatsApp. Right. So I will talk about one slide on each topic. When to use antibiotics, the indications, the brief introduction about indications, and then the guideline and some adverse outcomes, how to manage, and then I'm not going to tell how to manage, but to be aware of, and then optimizing the use of antimicrobials. So antibiotic use in this book we describe under two sets, like therapeutic use and prophylactic use. So therapeutic use is mainly empiric until we diagnose the organisms by microbiological diagnosis. It's empiric use. So empiric use by the system, you have guidelines are there, and then specific use is after confirming the diagnosis when you have taken some specimens for culture and the ABST is available, and then you treat according to the ABST, that is for the specific use. And prophylactic antibiotic use can be either medical or surgical. It's all given in the book. I mean, not go into details. And then the question is which antibiotic to use. So several factors are there that you have to consider when you're treating any patient, adult or pediatric, the systems involved and the severity. And host factors, like there are some patients who can have serious consequences of infections like immunocompromised children, children who have undergone surgery, like that you have to consider. And then the etiology, whether it's bacterial, viral, fungal or parasitic, that you have to think of the possible etiology of the infection and the source, whether the patient has come from another hospital, because sometimes we see patients transferred to LRH from other hospitals with various antibiotics. So you think of possible resistant organisms, and then the source of whether it's a community acquired infection, which is likely to be sensitive to many antibiotics. So those are the things, factors that we consider when suggesting the empiric therapy. And why we should be careful about antibiotic use. Most of us, like when I use the term antimicrobials, we think of antibacterial, antiviral, antifungal, and antiparasitic. All together we call antimicrobial, but mostly we use antibacterial. We call it antibiotics commonly. And then adverse effects you have heard about during the last year and this year also, some anaphylactic reactions and all the reactions which will be a problem for children, especially because they will be kept out of that antibiotic will be not given to that child. That option will not be available for a lifetime. So some antibiotics we ask you to give as infusions. All those instructions are given in the book. And allergies, of course, when you are labeling, like anaphylaxis, of course, you have to diagnose and treat immediately, but there are very different types of allergies. So you don't, when you write down anaphylaxis, you write down it very clearly, anaphylactic reaction, because there are cross reactions. Now, if it is a cephalosporin allergy, we can't use beta-lactams if it is anaphylaxis. But if it is not anaphylaxis, other things we can use. Like that, allergies we have to recognize clearly, and the toxicity of antibiotics for long use. You have seen many adverse effects on antibiotics. If you see the BNF or other books, we have not given all those things as details, but we have to consider the possible toxicity if we keep on giving, and dosage adjustments and all those things we'll have to do. And the problem of resistance, actually, that is when we keep on using antibiotics, that is the other problem, because it's not like any other medicine. When we use any antimicrobial, resistance is the problem. So that resistance may be affecting the patient. The morbidity, mortality will go up, and then the system also, when we have to use multiple antibiotics, the cost will go up. That will not be counted in the state sector. But if you go to the private sector, you see the cost of antibiotics is the majority of patients will be antibiotics if they use. And then that will be another problem for our quality of care, because if we have a lot of patients dying with sepsis or septic shock with resistant organisms, that will affect very poorly on our quality of care. And antibiotic resistance, other problem is it is spreading. So if you have one patient with resistance in an ICU, it can spread to other patients as well. So it can spread within an ICU, within a ward, and within a country also it can spread. Sometimes you may see patients with resistance when they are discharged from the hospital. After a few months also, they may come back with a resistant infection. And globally also it can spread. So Health Ministry as well as WHO is very much concerned about these organisms with antibiotic resistance. And we have to report also nationally. We have to report to WHO about our resistance profile. And then we will have this threat of losing the efficacy of antibiotics. In future, we will not be able to treat infections effectively. So that is the threat. So what can we do? This is the most important thing. So one thing is to raise awareness, because most of your patients also, they might demand antibiotics when they come to you. So you should not be treating viral infections with antibiotics like that. You have to make patients aware about the usefulness and disadvantages of overuse of antibiotics, and then prevention of infections. Health messages should go from patients to the from doctors to patients. That is also one of our responsibilities. And then whenever possible, we try to do what microbiological diagnosis and diagnose what the organism is, and then the sensitivity pattern, so that we can give the specific therapy. And then surveillance purposes, also this is important, because we have to, as a country, we have to report to WHO about our resistance patterns. And what other things that we can do, that is, as doctors, we have to optimize the use of antimicrobial. So we can use this book that is available now for empiric and prophylactic use. And then there's a classification given on antibiotics. The Ministry of Health has given with the WHO a classification of antibiotics into 3 groups: access, watch, and reserve. Because access antibiotics can be used to treat most of the infections, simple infections. And if it is serious infection, you may have to use a watch group. So there's a circular issued by the Ministry of Health that will be given to the wards in near future. So we have to follow those instructions. And then we have to use an antibiotic prescription chart. That is something that is ministry has given it to us. It has been made available through the government press, and it's there in the LRH store. So it will be given to the wards now. So there are certain things like patient identification and all those things the nursing staff will fill, but there are things for the doctors to write in that antibiotic prescription chart. One thing is the allergy. So if the patient, when you talk to the patient, if you get any history of allergy, do document that allergy. And then when you use an antibiotic, indication for the use of antibiotic, and then the type of use, whether you are using it to treat an infection, or if it is treatment, whether it's empiric treatment or whether it's specific based on an antibiotic sensitivity report, that you have to write on that. And then the generic name, obviously, we can't use any brand names on BHTs. And the route dose and frequency, as well as if you're trying to give it as an infusion, the duration of infusion. So vancomycin, most of you have had the experience. If you give it as a quick bolus, the patient will come up with red band syndrome due to histamine release. That is one example. So many of the antibiotics now we ask you to give as infusions of various durations, so that you have to write down on the card, the chart. And then when you take culture, the date of cultures, I'm rushing through because I have to release you. And where category actually, whether the antibiotic you are prescribing, whether it's an access group, watch group, or reserve group, you have to write. That circular will be distributed to the wards soon. And then you have to review any patient on antibiotics. You have to review daily, but at the end of 48 hours, 7 days or 10 days, you may decide to continue the antibiotic, or you may decide to escalate. Because if the patient is not responding, you have to increase the cover, or else if the patient is okay, you don't need an antibiotic, you may even stop the antibiotic for de-escalation, or sometimes you may decide to report to microbiology. So that decision you can write down also there. So this is all about the charts and everything. But if you have any queries, we are available. You can call us and find out the details. So the charts and documents will be distributed to the wards. I think it's already given. Nursing staff have been advised to collect the antibiotic prescription charts from the stores. So when they use antibiotics, all antimicrobials, when you prescribe, use this chart to prescribe that. So that is the main message here, because this will be audited by the ministry, and many hospitals are using. We have not used it so far. So from this month onwards, we are going to use this special chart. That's all about it. Any questions? I think we are available. My team is available to answer. So you can discuss with us. Right. Thank you. This book can be downloaded from the College of Microbiology site, and the PDF is also on the group, I think.
Thank you very much, madam. I kindly invite you to stay for 2 minutes more because our sponsors has a small presentation also. So I will request all the audience to stay at 2 minutes more for the sponsors, today's sponsors, BAM Green Solar, for their presentation.
Okay, good afternoon. I'm Tushar, gentleman from BAM Green Solar. I would like to introduce my company for the renewable energy. We have been in the industry in 14 years. BAM Holding is the parent company and BAM Green is the child company. Same directors owned by the BAM Green. This is our vision mission. This is the founder, Mr. B.A. Mahipala, the board of directors. These are the products on-grid, off-grid, and hybrid system. These are the three products we can introduce to our customer. On-grid is connected with the CBO LECO grid system. Off-grid is isolate from your CBO LECO system. Hybrid is both are together. That can work. It's mean if there is a power cut, you can use a hybrid system or off-grid system. These are the products we use. REC is a Norwegian product. J Solar, Chinese product. Jink also Chinese products. These are the inverter we use. Ponius is a German product. SMA German product. And Solis is a Chinese product. These are the inverter battery we use for the off-grid and hybrid system. Victon Energy is the recommended Gowet and Huawei for the hybrid system. Our main customer is BOC, Sampath Bank, People's Bank, Melbourne, Keels. These are our product. We are the introducer net metering system to Sri Lanka and Net Plus system, Buttala, Miami in 2017. There are many financial methods we arrange. We have signed the agreement with Bank of Ceylon at the interest rate of 7%. And DFCC Bank credit card system offer interest free 48 installment plan. Mainly, I would like to highlight why you should go for the solar with the BAM Green because of the financial arrangement. And other is we have 48 hours backup breakdown handling staff, and we handle the whole island breakdown within 48 hours. And we have maintained the backup material system. This is the only one company in Sri Lanka maintain the backup inverter and system. We can't assure the whatever the electric equipment. If it is failed at 1 second, we replace one-to-one inverter. And why with this I can highlight this for the doctors. You know, we have to pay the tax, and direct tax. When you calculate the taxable income for the year, if you invest in 600,000 for the solar system, you can deduct directly taxable income. These are the key benefit to if you go for the solar system. You can continuously deduct for the whatever the amount you spend for the solar system. And thank you very much.
Welcome to BAM Green, the pioneers in domestic and industrial solar energy systems in Sri Lanka. BAM Green offers you a wide range of solar energy solutions with high-quality European products, together with exclusive warranties and outstanding after-sales services. Our engineering, technical and customer care teams will take care of your projects from start to completion. From inspections, system designs and installations of solar PV systems, wind power and hybrid solutions, we handle complete systems integrations. Talk to one of our solar consultants to discuss your project and help save our Earth. Go green with BAM Green. BAM Green offers you a wide range of solar energy solutions with high-quality European products, together with exclusive warranties and outstanding after-sales services. Our engineering, technical and customer care teams will take care of your projects from start to completion. From inspections, system designs and installations of solar PV systems, wind power and hybrid solutions, we handle complete systems integrations. Talk to one of our solar consultants to discuss your project and help save our Earth. Go green with BAM Green.